Hello, everyone. We'll wait a couple of minutes for more people to join, as I'm sure they'll be grabbing their lunch ready for the webinar. Thank you, everyone who's joined us so far. Today's webinar is on structured questions and the power of eConsult in helping you triage faster and ensure that what you have received is clinically safe. So we'll wait a minute or two, and then we can see the numbers increasing. Great. Well, welcome everybody. My name's Faye and I'm the Operations Manager here at eConsult, and I'm joined by Dr. Dyer Smith as well, a doctor at the Hurley Group. Today we've got an interesting webinar. We're going to go into some detail, including some demos. But first off, let's go through just some of the housekeepings right now. Brilliant. So what's on the agenda today? We've got 4 key areas. We're going to start off with a bit more about eConsult and the clinical safety areas of it. So that feeds really strongly into those structured questions. And we'll also run through things like flagging, redirection, filtering, and sorting. And then the next section will be on how to read an eConsult. So once you've got that, what to look out for, and how best to work through that. And then the final bit is, or the penultimate bit, is going to be those scenarios. So as I said, we've got 6 scenarios, 6 different examples of eConsults, and we will go through the submission from sort of the mock patient, and we'll ask you what would you think to do next? What would be the next steps, having seen that information? And then finally, we've left some time for a Q&A. Any questions that we don't get to answer, we'll get over an email with any answers and any extra information needed. Brilliant. What I'll do now is pass over to Dr. Dyer Smith, who will take on.
Hi, everyone. My name's Dr. Ross Dyer Smith. I'm a GP in the Hurley Group in London, which runs 11 practices across London, across 8 boroughs and 3 ICB areas, covering about 120,000 patients. I've been online consulting right from the very early days, from 2014, I think, was my first eConsult. So I've done thousands and thousands of eConsults over the years. The Hurley's probably done almost 1 million eConsults across all those patients. I'm also the person who set up the first eHub in the UK, which is basically running online consultations at scale across the whole group. So we have a single point of access that goes to a team of over 60 clinicians who can help deal with eConsults and redirect them. So let's just move on. So why eConsult? I mean, it's designed for remote management. One of the key things that it has is red flagging, and that's about basically taking a proper structured history like we would in a consultation with a patient, and being able to focus in on particular symptoms that are important, so that you're able to make a decision about clinically where that patient should go. It aligns with the changes on the GP contract, and a particular one that you may have seen that may be enforced upon us is actually having your online consultation provider open the same hours as your GP practices, which we've always done in the Hurley, and it's entirely possible if you use eConsult. It's much more difficult with other products, and you'll see why, because of the safety features I'm going to show you in a minute. You can work at a federated level, like in an eHub, with the smart inbox features that enable that to be possible, and it means that you can navigate people to the right team, the right level of risk, saves on appointments, and gives you control over how you work and the volume that you deal with, and has all the communication functions that you'd expect from an online consultation provider. Most of this stuff you know, because you're probably eConsult users, but if you're not, that's the reasons why you should be. Safety is a really, really big feature. But the flow, and we'll touch on that in a minute, but the flow basically is patient comes through various routes, through the NHS app, through your website, or if you're using eLights, which is where a receptionist can actually take an eConsult down from a patient. They can be signposted to self-care, pharmacy and local services, and you can signpost them away when they get through into the actual online consultation itself. There is capping and open and closed hours and ad hoc management of your flow if you want to. But the key bit is the sort of digital triage and being able to move those patients to the right team members in your practices, and enabling quite a high level of remote management when required, and getting those people who need face-to-face in front of a clinician because the need is there and the urgency is there. And again, we're going to show you some of that in a minute. So this just is a sort of an idea of how it kind of deals with risk. So there's two ways you can do online consultations. You can basically just hand the risk straight to GPs and just say, here you go, here's what the patient has said, which is similar to just using email in my view. And there's no ability to screen patients out. Now, eConsult being built by GPs, of which there are sort of 12 senior ones still in the company who help design and work in the governance team, we know that GP practices and GPs are essentially risk managers. And what we're trying to do is take some of that risk away from you, or give you the ability to manage that risk the way that you see fit in your practice, because every practice is unique and every practice works differently. So the core of what we're trying to do is keep it safe, but give you the control to do and operate the way that you want to. So there's an emergency disclaimer, a bit like NHS 111. Have you had a stroke? Have you had a heart attack? Obviously, it immediately diverts people. There's then another filter if you happen to click on a very, very serious symptom. So something along the lines of, I've got a thunderclap headache, which might be a sign of a subarachnoid hemorrhage. That would again divert you away and say that this isn't the right route. And some slightly softer urgent symptoms, which may divert you to 111, depending on how you've set up and configured your online consultations. And we'll show what happens to some of those if you want to have them come through, because some practices prefer to. And then right at the bottom there, you'll see a big chunk of them will also identify particular symptoms and signs that are flagged so that you can see and make a decision about what you feel is the right and clinically appropriate route for that patient. Now, one of the things I'm going to try and show you is actually something that some of you may not be aware of, which is actually we do have a facility, and this is the 111 thing. We do have a facility within eConsult that means that when you actually get to the point where you're going to write something in the free text, that we've made consideration for things that might happen that are unexpected. So this is just a normal depression consultation. Now, if I go to the next step, it just takes me to the next step. Now, what I want to show you is what happens if I put now, if you see what happens, see how the next question has changed. It's recognized that there's a risk there to that patient, particularly around self-harm and suicide, and has immediately flagged it and made sure that that patient gets the right care that they need, and gives the ability for us to assess it as well. Now, that came out of a clinical incident many, many years ago. And this gives you assurance as a GP and as a clinician that actually those patients, and as a GP, and for all of you out there who work, the Friday afternoon 6:25 mental health patient that is suddenly suicidal just when you think it's the end of the week. That really does happen quite a lot more frequently than we would like. And obviously, if it comes through an online route that hasn't got an ability to flag them out in any way, then actually, that could be sat there till Monday, and you don't want that to happen. So this is specifically designed safety features to make sure that those patients are dealt with appropriately. So I thought I'd just show you that one. Moving on, we're just going to show you some of the smart inbox features. So I've done the self-harm for you already. The next one's just around signposting. So this is the smart inbox here. This is the sort of nav bar. When I was talking earlier about the sort of lower level urgent flags, some of you may have this turned on in the smart inbox, so you can allow them to come through. So these are ones which normally would have been bounced and said you probably need to speak to your GP, or you probably need to call 111. You can let them through, and they're in this queue here. So if you do have this on, that's the first thing you should go to, and that's the first one that you should look at. Now, the great features in the smart inbox are, again, all about risk management. So the first thing that I can do is give me the oldest one, or I can say, give me one of the most flags. That's the one that's most urgent, and I can go down that way. Or you might say, do you know what? Let's sort out all the kids first, and then let's sort out all the elderly. So you've got the ability, again, to work the way that you want to work. One of the other things, so that's the sorting. One of the other things I wanted to show you is also the filtering function. So if we're just going to sort by newest to oldest, but if the filtering is slightly different. So well, here what I can say is, and this is quite good for reception, for instance. So once somebody's triaged their eConsults, which we're not going to cover today, but you can get a receptionist, for instance, can say, right, give me all the ones which have been assigned to a GP for today that are face-to-face, and you can book all of those in. And of course, the receptionist can also say, give me newest to oldest, or give me the one with the most flags, and I'll put that one in first. So it's designed about being able to see or get to the patients that are the highest urgency first. And this is something that obviously we never really had available to us when we used to do telephone triage. It was just one long undifferentiated list. And this is a way of making that list differentiated so that actually you can pick out those people and how and when they need to be seen. If I just remove that filter, I'm going to show you another one that I quite like. This is one where we can, in the Hurley, for instance, in our eHub, one of the things that we learned was, and again, through just experience, that if you didn't get to the young women who had urinary tract infections quite early on in the day, they would often sort of do an eConsult, try and contact the practice, call 111, go to ED or an urgent care centre. And in some cases, they do or try or do all three. And we realised very early on that actually they were a very, very quick clinical condition to deal with. And so we found that we can filter by those and say, right, do you know what? I want to deal with the all the urinary ones, and you just filter it by the actual template itself, and you can filter that way. Again, you can do the sorting by urgency. There's only one in here, but you could sort by urgency, give me the ones which are the most serious. You've also got the ability to filter by these tags. So tags are something you can add to any one of these cards, however you like. You can see down the left-hand side some of the tags that I've created here. So I can either search for them in here and filter by urgency as well. So you can come down here and say, give me the urgent ones, give me the ones which are either assigned to me, or I like this one, which is quick wins. Again, it's brought out the same one here, but the one that I particularly like is, and when we say quick wins, just for clarity, these are conditions, a bit like UTIs, for instance, that we know are very, very quickly to solve remotely, and you can put them all in a pile. And when you click on this here, quick win, it puts them there. Again, I can sort by urgency or filter by whichever ones I want, and start with that, rather than, again, the previous functionality that we used to have as GPs, which was, start from your top of your EMIS or System 1 appointment book and work your way down. This is a way of making sure that you get to those serious ones first. And it's a fantastic for things like, CPCS, if you want to signpost to that, or if you've got potentially PAs in your organization, you can use it for that as well. So that's a great function of being able to sort of manage risk. So we go back to the slides here. So the next bit was just showing actually how to read an eConsult. Now, forgive me if I'm teaching some of you things you already know, but I'm caveating that I'm going for complete novices right the way to people who are very experienced. So I'm just going to show you how over the years my reading of eConsults has changed, and try and demonstrate what I focus on when I read one. So I'm just going to go back just to the all open one. I'm just going to go to some of the newer ones here. But if I just pick an eConsult, the way I'm looking at this right now is I'm looking at the condition template. I'm immediately looking at the age. I'm looking when it's due. and then I'll just take a quick note of whether there's any flagged. But as a general rule, what I'm going to do is anything with an icon next to it, I'm going to read or review, and everything else I'm actually going to ignore. Now that sounds a bit strange, but actually when you first start online consulting, you probably won't have a great degree of trust in what's written. You want to see it for yourself. But what you find, having done thousands like myself, is actually you learn to trust the technology and the questions that it asks. It's going to take a better history for acne than you probably would have done in a face-to-face, just purely because it will ask questions you probably would often forget to ask, or maybe don't seem relevant at the time. It will take a very good history. And so, you know, in a cough template, I know that I don't have to look to see whether there's a fever recorded, because it will be flagged. I know what will be flagged. I know all the important stuff will be flagged. So I literally just read the free text, and I'm looking at the free text, and I'm looking at anything that's flagged, and that's what I'm using to help make a decision. And then I'm moving on. So it's gone from my very early days where I read every single line meticulously to skipping very, very quickly through to the pertinent information. Very occasionally I will go back and look for something specific, but most of the time I'll be skipping through quite quickly. Obviously on occasion down the right hand side here, I might want, in the smart inbox, you've got the ability to look at the activity and what's happened, and when was it triaged, and are there any comments and such like, and they'll all be down here in the right hand side. So that's something that you can look to if you feel it's relevant. So there's an example there of the audit trail on the bottom right there. Comments is probably the one that most people would utilize if they want to pass a message between clinicians if they've been triaging, for instance. And again, this is the signposting section for doing that triage when you've got an online consultation. Today's mainly though around actually what do you do as a clinician when you've got an eConsult. So I'm kind of assuming in this case that most of these eConsults we're going to talk through have kind of already been triaged, and you're a clinician trying to make a decision about what to do with them. So what we're going to do is, as Faye said earlier, is I'm going to put up a couple of scenarios, and there's going to be a poll about like an MCQ. Now I'm going to caveat, there isn't really a wrong answer, okay? So don't feel afraid. And if you're not a clinician, feel free to have a go. But it's designed to make you think a little bit about how you might practice, and whether you might be able to change the way that you practice. Some of them is going to range from quite simple to quite complex and maybe even controversial. And again, it's done intentionally to make you think. Now, this would normally be, if I was teaching somebody or a group of GPs, normally I'd be doing this face-to-face and spending 2 or 3 hours doing proper case-based discussion, which is the best way to learn on how to do this. In the Hurley, we have sort of regular meetings and case-based discussion. We've got a very, very active Teams group of people actively consulting, but 60 plus clinicians all chatting all the way through the day. What would you do with this? What would you do with that? And it creates a brilliant learning environment. So that's another way of yourselves being able to try and replicate that to become better and more efficient at online consulting. So what we're going to do is I'm going to show you a scenario. I'll put it up on screen. I think you can also see the PDFs in the chat as well if you want to go on a bit longer and read a bit more detail, but I will go through relatively quickly in the interest of time. So this first scenario is a 28-year-old female. There's no past medical history except a UTI 6 months ago, which was treated with nitrofurantoin. There's nothing else relevant in the notes. So this is the eConsult you see. So the poll is going to come up in a second. Hopefully Faye's going to do that. So what's the next thing you're going to do? Are you going to sort out some urinalysis for that patient? Are you going to prescribe an antibiotic after you had a look in the notes? Are you going to ask the patient to come in for an examination and urinalysis? Or are you going to call up the patient and opt for a watch and wait approach? So if Faye does the poll, that poll gone? Faye, I can't actually see.
Yes.
So you're gonna have to let me know.
Yes.
Yeah. I can't actually. What have we got?
The results are 36% for A, 40% for B, 24% for C, and nobody has chosen D.
Okay. Okay. Very interesting.
And we've also had another question: could pharmacy first deal with this as well?
Well, absolutely. Yeah. These scenarios were written a very, very long time ago. So absolutely, that's a possibility. And that's because it's this was written probably, I think, before we had pharmacy first, but absolutely yes. So yeah, look, there's no wrong answer, but I think what I would say is I bring this one up because I think this is one of the quick wins that you see in primary care. The urinary tract infection in young women eConsult is absolutely brilliant at taking the perfect history and very quickly risk stratifies for you whether it's a safe patient to deal with or not. And in this case, it is. There's no significant red flags. The Health Protection Agency guidance for management of UTIs, if you've got 2 or 3 symptoms or 2 or 3 major symptoms in a young woman without any other major health problems, that you can treat empirically with an antibiotic. Absolutely. So urinalysis actually isn't in that flow at that point. For older patients, it is. But in most cases, you probably wouldn't do that. And I think post-pandemic, people are much more comfortable with doing this. Pre-pandemic, I think people weren't, but now they realise this is really where online consultation is excellent. And as I've said, these patients are really in quite acute distress. Having a urinary tract infection is truly awful, very easily treatable, but it's quite hard for patients to get access. And this is a really, really good way of giving a patient an excellent experience and very quickly getting them to treatment. But again, none of those answers are wrong. So don't feel if you didn't pick that that's not the right thing, but it's just about thinking about what you've got in the history and what enables you to make that decision, because all the information is there. You don't need to make any more. You don't need any more really history with the notes and that history that you've been given in a structured form with those flagging capabilities in there as well. Okay, so next scenario. This is a 47-year-old female, no past medical history, no drug history. My last consultation was over 5 years ago for a fungal nail infection and really nothing else in the notes of note. This is the eConsult. Okay, so the next poll. What do you do next? Do you send the patient some NHS online advice about knee pain and prescribe them some naproxen with a follow-up plan in 2 weeks? Do you send a message to prescribe some naproxen and refer to physio? Do you call up the patient to discuss a bit more? Or do you invite them in for a face-to-face appointment? So I think Faye will open the poll, and Faye, you're gonna have to just let me know when it's done. The results are, if that's okay.
Yeah, we've got the poll going. Okay. Right, so we've got nobody's said option A. 52% have said option B about sending a message. 19% would call the patient and 28% would invite for a face-to-face.
Say that again to me. Sorry.
So 0 for A. For B, 45%. 20% for C and 33% for D.
Okay, very interesting. Okay, so this one is a little bit of a trap. So one of the things that's leveled at online consultations is people will often say things along the lines of, oh, what about non-verbal cues? That's the classic one. What about non-verbal cues? You know, you can't deal with patients remotely. What about non-verbal cues? Well, the written word is a non-verbal form of communication. And actually, just like face-to-face consultations, you start to get a feel for how people communicate. And when you've done a lot of them, you start to spot things of significance that maybe you wouldn't have picked up early in your earlier career. And that's just through experience and sort of this sixth sense that you develop in medicine. But the same thing happens with online consulting. Now, I'm just going to go back. It's a completely innocuous consultation. There's nothing really exciting in it at all. She's got knee pain, nothing major going on there. She probably just needs a bit of help, absolutely. But in my view, I would have gone for C, and I'll show you the reason why. Well, C or D, actually. And it's there. And this is what I mean by a non-verbal cue. This is a real consultation that I had a few years back. And actually, as I was reading the online consultation, I'd already made a decision I was going to do, you know, here's some pain relief and we'll refer to physio, see if we can get you sorted out, give you a bit of help. But actually, as soon as I saw this history bit down the bottom, my dad had osteosarcoma of the knee and had his leg amputated. Immediately in my head, I was thinking, if this was me, that is what I'd be worried about. She's talking about prolonged knee pain with no real trigger. She hasn't mentioned it, which often patients do. You know, they often don't reveal their reasoning for consulting. And I made the decision just based on this to call this patient, I think. Yes, it was a call, because I knew that's what she'd be worried about. And that was the case. So this is an example of what I describe as a non-verbal cue in online consultations. But again, there's no wrong answer here, really. Because actually her risk of being osteosarcoma being incredibly rare and her age it's very unlikely. So it's perfectly reasonable to have any of those other suggestions, I think. But it just, again, it's just to show you kind of the nuance that occurs sometimes when you've got a structured history. You can pick out little bits because it's separated out. It's not one huge dump of free text where you're trying to decipher it. It's separated out, and you can see that bit nice and easily and highlighted, and it gives you a clue on what to do next. So that's an interesting and challenging one. Scenario 3. So this is a 19-year-old female university student, recent consultation for oral contraceptive pill and on microgynon. Nothing else relevant in the notes. So the next poll is this. Would you A, arrange for face-to-face or video consultation, B, refer the patient to mental health services and send a message saying that you've done so, C, telephone the patient to discuss her options, or D, send a message with a link to the local sort of self-referral IAP service with advice on self-help and safety netting. Vote away.
Right, so we've got 17% would choose option A. We've got 5% with option B for mental health. C is 61% and D is 19%.
Okay. Again, none of those are wrong, just a caveat. So the reason why I put this in here is actually the particular opening for this patient. So there's not particularly anything of huge alarm. She's been quite specific on what she actually thinks she wants and needs. And you know, she's done her PHQ-9 and her GAD-7. But what she's stated right at the top there is that actually she wants contact via email, which a lot of these sort of young people actually find that that's an easier way to sort of communicate. And it depends on your level of comfort about dealing with mental health problems. Again, I've got a high level of trust in the questions that have been asked and in this template. I myself would probably go for C or D. Both of those are kind of something that I'd be more comfortable with just from doing it many, many times. But again, none of them are wrong. My reasoning behind it is because, again, it's relatively low risk history. There's nothing in the notes of alarm, and she's specifically asking for a particular route of treatment. So that's quite an easy one to potentially close remotely and make sure you're putting across that safety netting advice that we always do in those mental health consultations. Okay, so scenario 4. This one is a 48-year-old male, past medical history 6 months ago, was seen for a minor work-related injury, and he works as a builder. The next slide is an enlarged one of his pictures, so there you go. So what are you going to do next? Arrange a face-to-face or a video consultation, call the patient to get a bit more information, call the patient, refer by 2-week wait, or make an appointment for cryotherapy.
Okay, so for this one, 63% pick option A. No one's calling the patient for more information. 23% are calling the patient for a 2-week wait, and 14% are making an appointment for cryotherapy.
Okay. So I think the key thing for this is this picture, which is brilliant, super high definition, very good picture that they've taken. That has a malignant melanoma with a satellite lesion. So again, it comes down to your level of experience of dermatology. My previous background was in surgery before I was a GP, including plastics. So I spent a lot of time cutting out melanoma. So my reaction to this is absolutely C. I know what I'm going to do. I can tell enough by the history and the risk factors that is, I cannot exclude a melanoma, even if I saw them face to face. It's not going to change my management. And when I teach people online consultations, I often refer to think like a radiologist. No disrespect to our radiologist colleagues, but most of you who were junior doctors would have at some point in your house years or F1 years been given a form and by your surgical boss and told to go and get a CT scan down in the radiology department, and you turn up sort of nervously looking at your feet saying, please, Mr. Radiologist, can I have a CT scan of this abdomen? And the next question out of their mouth would be, what's the indication and how's it going to change your management? Which was always an awful question because your boss never told you that. But anyway, the point being is that that's the question you should ask, because it is a very good question. Of these actions, is it going to change what your inevitable outcome is going to be? Because if the answer to that question is no, then actually you should, there could be an alternative route. So when you look at the history of this chap who's saying he's got it's on his arm, it catches, it bleeds, it's big, we know he's a builder, which is almost a risk factor in itself, and again, like the sort of size of it and that picture, I'd just refer straight on, make sure there's no delay, and get them assessed in the clinic that they need. So that's the reason why that's there. Again, we don't always get high quality photos, but sometimes we do. And I'm quite I'm quite happy to message a patient several times to get good photos, and I've got a sort of standard template that I send out about how to take a good one, because often patients struggle a bit with their phones sometimes, but actually it's worth the effort to get a good one. But occasionally for other dermatology cases, it's not clear and you need to get them in. There's no doubt about that. But that's why this is quite an interesting one about how people might do things differently. But yeah, so let's move on to the next one. Scenario 5, a 33-year-old female, several months of diarrhea. She's been using codeine to control it and has been referred to gastro last week by a GP and has had her investigations done. So what's your next course of action? Do you issue the codeine? Because I only had 2 weeks worth of it. Do you call them to discuss about the risk of opiates? Do you issue the medication and send a message saying you'll also send a letter to expedite their gastro appointment? Or do you do something else?
A few more responses coming through. Right. Okay, so no one would just issue the medication. 26% would call to discuss the risk. 52% would issue the medication and send a message saying you'll also send a letter to expedite. And then 21% would do something else.
Okay. So this one, again, is based on a real online consultation I did a few years ago and is intentionally slightly provocative to all the clinicians out there about how you might manage some of these conditions, about what you can manage remotely. And this really is pushing it kind of to the extreme. But one of the things that we said earlier on is that she'd actually been to see a GP and she'd had some tests done. So let me show you those test results. So negative stool culture, CRP of 7, raised DSR, below HbA1c and MCV, raised platelets, normal liver, renal, thyroid function, normal celiac screen and normal calcium, and a raised fecal calprotectin, significantly raised at 431, which is a young woman. So just to caveat that. Now, the reason why I put this up is when you looked at the history and went into the notes, actually, it became very clear that this woman had inflammatory bowel disease. And obviously, I had the advantage of having these test results in the notes as I picked up this eConsult. So my first reaction was, oh, this is someone drug seeking. Then I looked at the history in the notes and realized, oh no, it wasn't. They had quite a serious problem, and crikey, they've got a 31 week wait for gastro. The previous GP had done exactly the right thing, recognized there was a problem that needed to be seen and done the investigations. But I realized at this point, the only thing I really needed to do was work out whether she had an acute abdomen or not, because I'd already was pretty convinced that she had either ulcerative colitis or Crohn's disease based on the history. So this was a phone call. And I rang her up, and I didn't take a history. And this is again one of the things that people often do is when they do a phone call from an online consultation, they open with, "So tell me about the problem," or "Tell me about your diarrhea." You've got the history. The trick is to ring up with some focused, closed questions, which goes against everything we're taught as clinicians. We've been taught from medical school or from wherever we trained in nursing or physician's associate training. Ask open questions. In online consultations, if you do them properly, when you're doing a subsequent contact like a face-to-face or a telephone call, the key is to focus very quickly into those closed questions that you would normally do further on in a consultation if you were starting out from scratch face-to-face. So in this instance, I rang her up and I said, "Hi, thanks for eConsult. I'm sorry you've had all this trouble with your diarrhea and the fact that you've got such an enormous weight. How are you?" And she told me, and then I said, "Look, the first question I've got is, have you got any tummy pain?" She said, "Absolutely not had any tummy pain at all, but this diarrhea is just awful." And then the second question I asked was, "Can I just check? Has anyone in your family had any bowel trouble or anything like that?" Her answer was, "Oh, my brother's got ulcerative colitis." Why she didn't realize herself that this may very well be her diagnosis, I was quite astounded by, but that pretty much sealed the diagnosis for me there and then. I had everything that I needed to make a relatively safe decision that she felt well, she was okay, she'd been in previously, and I rang up the IBD clinic and got her seen the next day. So it went from somebody who was waiting 31 weeks to potentially see gastro to me dealing with a case completely remotely and sorting her out. And obviously, from her point of view, that was an incredible experience. So it really can facilitate really quick care for patients, even those who are quite unwell. But all the questions prior to this actually did exclude those very serious conditions like septicemia and major health issues before she'd been able to submit her eConsult. So I knew she wasn't a particularly high risk patient in that regard. So that's a controversial one. So let's move on to the final one. I think we're on now. Again, this is another controversial one. Let's see how people respond to it. So it's a 32-year-old female, fit and healthy. There is a previous entry in the notes about a breast lump 2 years ago. The GP had seen her and examined her and said they couldn't feel anything. And this was her consultation. So what's your next course of action? A, arrange a face-to-face. B, call the patient to gather more information. C, call the patient and refer by 2-week wait. D, call, review, and arrange a follow-up. E, do a video call.
Okay, the results from the last poll is 72% would arrange a face-to-face. Nobody would do option B, call the patient and gather more information. 22% would call the patient and refer by 2-week wait. 4% would call, review, and arrange follow-up, and nobody would arrange a video call.
Okay, so there's 22% brave people there. I mean, that's the decision that I made. Again, this is a real one. But there isn't a wrong answer here. So the people who arrange the face-to-face, that's fine, what you're comfortable with. The reason why I made the decision to just do the 2-week wait was this was her second presentation. She was adamant there was a lump. I knew that I was going to call her, and I thought to myself, if she comes in and I examine her and I don't feel anything, what am I going to do? The second presentation, she's insistent she's got a lump. am I just going to send her away and reassure her, or am I going to refer her anyway? And the answer was, I'm going to refer her anyway. So again, that same question, is it going to change your management? And the answer to the question was no. So I thought, there's no point in me bringing her in. I'm going to call her up. And that's what I did. I called her up and I said, look, is this the same lump you had 2 years ago? She said, yeah, it's definitely there. It's something's not right. I clarified a few more just about where she felt it, just checking it wasn't actually something in the skin. She was like, no, it's definitely in my breast tissue. I can feel it. And I referred her by a 2-week wait there and then, which meant that, again, I didn't fill up another appointment that day. She was quite happy with that. I did offer and said, look, you can come in if you want to talk about it, obviously. And I think whenever I do remote 2-week waits, I'm always conscious that patients may have lots of questions, but actually most of them, when I've done it, are very, very appreciative of the action. And actually, in these cases, that's what they're worried about. She was worried about cancer, obviously. It has met with a little bit of resistance pre-pandemic from our secondary care colleagues at times when I haven't examined patients, but I'm always justified when I write the letter as to why I haven't. And I did in this case, and the consultant was perfectly happy with that. And actually, this did turn out to be a breast cancer, unfortunately. And the outcome wasn't great, but again, she was diagnosed, seen, and sorted very, very quickly after that online consultation. That obviously, if you think about if she'd come through for perhaps a face-to-face in the old ways of working, she probably would have waited another 2 weeks to get in and then be seen, and then wait another 2 weeks to be seen. I think she was seen 3 days later. Yeah, it comes down to your risk appetite, this one. So if you're not comfortable with doing, a referral straight off the bat, then actually that's completely fine, getting them to see face to face. But this is why reflection is so important, and why we encourage people when you do online consultations, especially if you have things like clinical meetings and stuff. It's a really good opportunity to just now and again have a session where you just put up some online consultations and have a debate between you as clinicians about what you would do, because everybody's risk appetite is different. But once you share how you all would address things and justify, actually your ability to assess the level of risk starts to change. So I'll often say to people, look, online consulting is a bit, it's a bit of the skills from telephone consulting. It's a bit of the skills of face-to-face, but it is unique in its own right. And recognizing that's really important. It's not the same. You can't crowbar the skills from telephone consulting into online consulting. Is a mixture. And this is what I'm trying to sort of show with some of these cases. And again, this is not full case-based discussion because none of you can respond to me, but it is one of the best ways of learning. So thanks for taking part in all of that. I hope some of it's been useful. And again, look, we are cramming stuff into a short sort of space of time. Some of the key messages really, my biggest ones are at the top there, like don't recollect the history. If you're going to contact a patient or do it face-to-face, you've got the history. Save yourself the time. They've told you all of that. Just quickly summarize and then get to the closed questions. Always be empathetic. And what I mean by that is if you're writing a text message to somebody, be empathetic. It's one of the things that we lose when we use that form of communication. Very easy to just use the words, look, I'm really sorry you're not feeling very well. It makes a big difference for patients when you speak to them. Have a think about, can you move the patient along their journey? So some of those referrals and such like, can you rather than sort of get them in for face-to-face or another appointment, what can you do now, investigations, etc., to move them along that journey that you may do anyway? Learn to trust the eConsult. That it's built by GPs who do your job, and it's built to be safe. All of those red flags and all the rest of it are there to make sure your patients are safe and that you can deal with them safely, even when demand is high. Just focus on the free text and flags if you want to get through stuff quickly. Stratify the risk using all those tools I showed you in the smart inbox, and you obviously use the triage function as well to do that. So you're always working from the patients that are at the highest risk, and that's particularly important at times when you've got really high demand. You know that you're dealing with the stuff that needs to be dealt with first. And again, what I just said is, could you have managed it differently? And the only way, if you operate in isolation, which we often do as GPs, and especially when we're working remotely and doing online consultations, you never learn from others or from reflection about what happened to that particular patient. So it's a really, really good thing to do in clinical meetings, even if it's just one a week where you say you pick up one interesting one and you will talk about it for 10 minutes or 5 minutes. You'll really learn from it. So thank you for your time. I think we're going to go over to some questions now from Faye for the last 10 minutes that she's going to serve up to me.
Yes, thank you so much, Ross. That's been brilliant. We don't have too many questions, so if anyone does have any questions following that, do pop them in the chat and we can answer them live. We've had some great responses from people who have talked about their local pathways and whether or not, like for example, that pharmacy first example, and sort of the offerings that they have in terms of dermatology on site at practice. Okay, we've got one attendee doesn't use the smart inbox, so their eConsults are submitted and are moved into an appointment triage list. How do you demonstrate workload in anticipation of automatic appointment extraction? It's a good question, more for sort of usage there. In terms
just
of...
to repeat the question, sorry.
So they're looking at, this is a little bit less on the triage front, more about how do you demonstrate workload in anticipation of automatic appointment extraction?
Oh, so I think this is probably about GPAD, I think.
Yeah.
I'm presuming. Yeah. So it depends on what your definition of digital triage is. So technically, when the eConsult arrives and you processed it, that's technically a digital triage consultation. Now, it depends on how you define it. But any follow-up, obviously, if you do a face-to-face or a telephone call, then obviously that is a subsequent appointment. But essentially, every eConsult that arrives for us has an appointment. So we make sure that that's mapped in. That's how we do it. I think that's answered the question. I'm not quite sure.
Yeah, I hopefully, if not, do ask another question and we can go into more detail. We've got someone who's asked whether or not you can delete tags. You can indeed delete tags. I'm just going to reply to you where to go for how to delete the tags and support from the team on there. Do we have any other questions from anyone else about sort of any of those scenarios today or sort of examples you might have? Okay, we've got a good question here. How do you moderate your appetite for risk?
Oh, what a good question. Yeah, so if I think back to the very first eConsult I did in 2014, it was for a UTI for a young woman. And I literally thought I was practicing some kind of danger medicine. I felt really, really vulnerable. I read every single line. I was petrified. I called the patient up. But I realized after the phone call that actually I didn't collect any new information. It was exactly the same information that I had in the eConsult. And the decision that I made was exactly the same I would have made if I'd just read the eConsult and trusted it. So my risk appetite has changed from experience. And also, as I said, discussing with people, excuse me. So having case-based discussion, whereas clinicians, you talk to each other because you each have a different risk profile in the sense of what you're willing to deal with. And that comes from our personal experiences as clinicians. All of us have had those nightmare scenarios with certain cases that tempers us for the rest of our careers. And we can be much more cautious I'm much more cautious about head injuries, for instance, having, missed a couple when I was a young SHO in ED. I'm much more anxious about those. But it's different for everybody. But the way you mitigate that is by talking to lots of other people who do it, because then you get an idea of where you are in the pack. I think that's the thing, is when you operate independently, you often don't know where you are compared to everybody else. So that's why case-based discussion is so powerful. And I've managed to moderate my risk appetite over the years by trusting the eConsult, talking to others to see how they do it, and questioning all the time about, well, could I have done it differently? And quite often you can do it differently. And actually, traditional ways of medicine are being turned on their head, and online consultation isn't really taught. I don't know why it isn't, but it should be. But it's a completely independent skill, and actually, like any skill, you have to practice it. You have to do it frequently. You have to reflect a lot, and your risk appetite will change as you realise that you've done 10 UTIs remotely and nothing untoward has come of it. It's good governance, of course, and making sure that if something does go wrong, that you do a significant event analysis and work out what went wrong and what you might do differently next time. But that's how you alter your risk profile and what you're willing to deal with, and talk. Have an open channel where you can all chat to each other all the time. So I say we use Teams. No patient identifiable information that goes on there, but it is non-stop during the day in our eHub. It's like everybody saying, what would you do with this, and where would you refer this, and can someone check this out? And it really, really helps you feel like you're not alone when you're making those what feels like slightly riskier decisions, and actually after a time you realize they're not that risky.
Hopefully that gave you a little bit more of a flavour. If not, ask another question and we can help out. So we've got a question about developing a care navigation tool to support triage, which could support decision making. Now I know, would whoever's asked that question, do you want to give us a little bit more detail? Are you thinking sort of AI within that care navigation tool?
I think probably the question phase around
yes,
having a kind of set protocols, like a standard operating procedure. What do we do with this? What do we do with that? And quite a lot of practices who are eConsult users have done that. We've got examples of that. So James Perry used to work with us, who's up at Marine Lake in Cheshire. He's got his own sort of care navigation sort of tool that he uses. He often uses the phrase triage out, which you'll see in the triage signposting section on the smart inbox. And that is things like anyone with an eye problem, send them to the local eye service or MEC service. And you can, put protocols in place to make sure those patients go straight to it. You could have an ANP who does your triage, who does it. Some people will even use highly trained administrators to filter out some of those ones as well before it even gets to a clinician. So again, every practice operates differently. I think a lot of the time we do get asked about how would you do it? And actually, whenever I go and tell people this is how we do it, most people change it immediately because it doesn't fit with the way that they operate. So, but there are plenty of examples out there, and there's quite an active community of eConsult users that share this kind of stuff. So, get in contact with the team if you're interested in finding out about some of those case studies and how they've used it. I think we might have time for one more, maybe, Faye, if there's anything.
Okay. So this one says, I don't know what this acronym stands for, hopefully you'll know. It says WRT, replying to eConsults via email option. I spent hours saving templates for frequent problems. Okay, that's just about whether or not there are plans to share it with the team. Yes, there are plans. We are just in the process of releasing the shared message templates. So work is going on that at the moment. So keep your eyes peeled for that. So we've got a question actually about the number of the series of questions, patients skipping to them, skipping most of the questions and already answered the questions, and a few are too deep.
That criticism's leveled quite frequently, and I think what I would say is look, if they come through the general advice template, which is much more disseminated questions, it will be longer for them. And so there's a lot of work that goes on to try and get the patient to the right template first time. So in the search function, getting them there to the right template. So we'll take a focus history. And yes, on occasions it is long. But what I found over the years that the more you're balancing between being able to control risk and being able to make a very quick journey. If you want a really quick journey, it's just purely free text. You are never going to be able to manage the risk. It's just impossible. You've just got a big pile of undifferentiated stuff. You might as well just get them to email the practice. You can't do it. So that's why it's so critical. And we're always working and look at the data around how can we improve the flow for patients to get through less questions without mitigating the risk for you at the other end, because that's what we're about, reducing the risk for you, reducing the risk for the patients. So it's something we're always conscious of, but we're quite proud of the fact that we take a very good structured history and we do it for a very, very, very good reason. And that is to keep our patients as safe as possible and you being able to deal with the sickest people first.
Brilliant. Well, that's it for questions. If anyone does think of any questions, feel free to email practice.support@econsult.health and the team will pick it up and we can get Dr. Dyer-Smith involved as well with any questions or queries. Thank you everyone who attended and did all the scenarios, and hope to speak soon. Brilliant.
Thanks everyone. Goodbye.
Thank you everyone.
Bye.